As we continue our exploration on the ABO blood group system, we have to understand that the ABH antigen and antibodies have a role to play as it relates to a diseased individual or a diseased state. So the associations between the ABH antigens are practically in any disease can create complications. Some persons have many myths that they say one blood group is better than another blood group, that one group of person like the A blood group is more inclined to criminal activity, a B blood group may easily easily have hangovers. Persons with O blood group may have good teeth. So all these things are not a true reflection of the blood grouping system, and they are just myths. So bear that in mind when you hear someone is saying that if you're this blood group, then this will happen. That is just fabrication, and you have to be wary and cognizant of that. But what I can say though is that various disease states seems to alter the red blood cell antigen, and when there is an alteration from normal functionality, what results is either progressively weaker reaction or the addition of an acquired pseudo antigen, which can be seen during either the forward, where we use the anti-series blood grouping. So when we use the anti-A, the anti-B, the anti-AB, the anti-D, and sometimes depending on what kind of grouping methodologies we're doing and what investigation, when we use the anti-H, we will realize that there is some weak reaction that is not really what we expect to see, but that is what we're getting. The next thing we want to understand is that persons with the big C, a lot of persons have the big C. First, it was the big A, now it is the big C. When we talk about cancers, there is a proliferation of a growth of a particular cell, and this can impair the blood grouping system and its representation. So when we think about a leukemic individual, a leukemic patient, a patient with leukemia, we have to think about leukemia, the chromosome 9 translocation, and hemolytic disease that can induce stress. Let us think about hematopoiesis. So we're going to be running through our mind like thalassemia have been shown to actually depress antigen strength. So if you have thalassemia, there is a possibility that the antigen strength, which means that antigens are on the surface of the red blood cell, those will be weaker. So cells will appear to give a mixed field agglutination. When people have a disease we call the Hodgkin's disease, there has also been reports of a weakened or a depressed ABH red blood cell antigen, resulting in a variable reaction during the forward grouping, similar to those found in leukemias. So the reactivity when you have Hodgkin's disease, you have leukemia, and you have certain kind of cancers, can reduce the reactivity. So the antigen strength increases again, though, when the person goes into remission. So yes, a disease means that the body is in a state of dis-ease, which means that the normal functionality, the normal operation, the normal protocols are not being executed in the way that the body would desire for it to be executed. And as such, there are challenges in the body's ability to mount up an adequate response to pathogens, to disease causing agents, to protect itself, and even to show who it really is. And when this happens, we have a situation where the body is weakened and compromised. We also have the isoagglutinins. So we have anti-A, anti-B, or anti-AB. These also may be weak or absent in leukemia, demonstrating hypoglobemia, globulinemia. All right. So you have low level of gamma globulins in the anemic state. All right. That's basically what the word. So hypogamma-globulinemia. All right. So when we think about this, we're thinking about chronic lymphocytic leukemia, so CLL. So you may come across this when we focus on hematology. Then we will see this being played out, and then we can put the pieces together to have the bigger picture. So various lymphomas such as malignant non-Hodgkin's variety may yield weak isoagglutinins. And this isoagglutinin is owing to the moderate decrease in the gamma globulin fraction. All right. If someone is immunocompromised, they have a immunodeficient state, or they have immunodeficiency disease, such as congenital gamma-globulinemia, they will yield weakened or absent isoglobulin, and they will probably in some instance have weak or absence in isoagglutinins. All right. So if this problem is suspected, a simple serum protein electrophoresis will confirm or rule out this condition. Did you know that individuals with intestinal obstruction who have carcinomas of the colon or the rectum or some other disease of the lower intestinal tract may have an increased permeability of the intestinal walls, which allow the passing of bacterial polysaccharide from E. coli. And usually the serotype that we're talking about is O86. All right. And this will pass into the patient's circulation system and result in what we call the acquired B phenomenon, especially in group A1 individuals. So the A1 individual can have an expression of a B based on the intestinal situation that is taking place. So when there is some form of carcinoma, there is some form of cancer in the lower intestinal region, this individual becomes compromised, especially by E. coli, which the body should naturally be able to pass out. All right, but you know that we have different classes of E. coli. We have the hemolytic E. coli, we have the regular E. coli, and this one that we're speaking about in this case is the serotype O86. All right. Now, the patient with group A red blood cell will, what they will do is absorb the B-like polysaccharides, which react with the human source anti-B. So the E. coli possesses protein molecules. These protein molecules can evoke a similar representation as that of the, and then it reacts with the human anti-B. So basically that is all that is happening. All right, very good. So the lack of detectability of the ABO antigen can occur in patients with carcinoma of the stomach and or the pancreas. All right, but serum contain excess amount of blood group specific soluble substances that may neutralize the antiserum utilized in the forward grouping have been observed in some instances. So these are just some things for us to note, that different disease state can impair how the blood group is interpreted. And with that said, I want us to be reminded that all ABO discrepancies must be resolved prior to a transfusion or the release of blood for a patient. So now, with that said, understanding this, that there are situations where the blood group that we get is not the one that is expected, let us embark on assessing the ABO discrepancies. So when we talk about ABO discrepancies, these are unexpected reactions that are observed in the forward when we add the anti-A, the anti-B, the anti-AB, the anti-D. If we're going to put that in there, because we usually do that part of the reaction. We're not going to talk about the RH system just yet. So we're going to just leave it at the anti-A, the anti-B, the anti-AB for now. But in the real world, we also in the forward have the anti-D as well. All right. Now, for the reverse grouping, there can be discrepancies. So it can happen in the forward or it can happen in the reverse. And with the reverse, we use the A1 cells, usually based on the population type and the population availability of that blood group, the predominant blood group that is in the population. Then we use A1, and we also use B. So the A and the B to confirm the forward. So that there would be the reverse. So those are the cells we use in the reverse, and we use the antiseries in the forward. So these unexpected reaction can occur in either the forward or the reverse. But What if we indicated to you that it can occur in the forward and the reverse simultaneously? That is a possibility. So these can be problem due to the patient's health situation. This can be problems due to exposure to something. This can be problem due to inaccurate sample. It can be a lot of problems that cause these discrepancies. So as clinicians, we have to be mindful in resolving these discrepancies so that the right patient receive the right blood that is compatible, that will be viable, as efficacious as it can be. All right? So technical errors are one of the errors that we need to speak about. So technical errors can also cause the ABO discrepancy. Example, if blood samples and tubes are labeled in error, failure to add the reagents as needed, we have cell suspensions are too heavy or too light, so we have prozone or postzone reaction. Then we have clerical errors in which incorrect results have been documented. We have a mix-up of the sample, so the wrong patient sample with the wrong label. Then we have mixed observation of hemolysis. So we missed that observation of the hemolysis. So we saw hemolysis taking place, but we never picked it up at the time when it was happening. So we failed to realize that something was wrong. So failure to add reagents, failure to add the sample. So we're doing the testing and we forget to add the sample. So that there's a problem. Failure to follow up with the manufacturer's instruction, because from time to time the manufacturer instructions will be altered, will be changed based on the batch of reagent that they are sending and what in-house testing they are doing to validate their study. So they may use a different reagent that need to react slightly differently than what you know, but you are going in with your mind to say, hey, this is how it has been done for the last 5 years, so this is how it should be done. But changes do happen over time. Then we have a situation where the uncalibrated centrifuge can either centrifuge too fast or centrifuge too slow, which means that you can miss the reaction, or when it's spun too fast, the reaction forms, but then it is broken up. So over centrifugation or under centrifugation, that there can be a problem. And if the centrifuge is not calibrated to the appropriate speed, then we are going to have a challenge. So we want to get rid of all of these technical errors that exist. If the reagents are contaminated, bacteria is in them, then they will fail to react as how they were intended to react. And sometimes we warm our specimen. So when we warm them, we can induce or introduce hemolysis depending on how we warm them. When we warm some reagent, we inhibit some of the reactivity. So we have to be mindful to avoid warming unnecessarily. So all of these situations can create a challenge in the blood grouping determination. But when the discrepancy is encountered, all results must be recorded, but interpretation of the ABO blood type has to be delayed until a resolution can be determined. And the information is recorded so that you can go back to see if what you got in the morning is what you got in the afternoon. And when we talk about morning and afternoon, we're not talking about in the morning when you did it or in the afternoon. We are talking about what you did first and what you did after to see if there is consistency. Just like when we have a transfusion reaction, we have to perform all the procedures that we did prior to dispensing the blood and blood products, and then checking again compatibility just to be sure. And then we're going to also perform a DAT on the first sample, the second sample, to see if there is any form of hemolysis, to determine if there is any form of sensitization taking place. So all of these things have to be taken into account. So transfusion medicine is very tedious, and you have to be on your A game if you're going to work in transfusion medicine. Working in transfusion medicine, working in blood banking, immunohematology, is like working in the emergency room. So you have to just always be as sharp as you can be, spot any deviations as quickly as possible, and take the remedial corrective actions that are needed to resolve such discrepancies. So we have discrepancies, we have encountered them, we need to have a resolution. But we have a situation where we have ABO discrepancies, and they are divided into different groups. And we're going to go through the groups: groups 1, groups 2, groups 3, group 4. And then we can come to the idea as to which group discrepancy we would prefer. So in group 1 discrepancy, discrepancies are associated with unexpected reaction in the reverse grouping due to weakly reacting or missing antibodies. And this one is kind of easy to identify, because a forward is going to give you a positive reaction, maybe 3 or 4 plus, and then the reverse is going to be lacking. So when that happens, you know that something is off, right? So these discrepancies are more common than those of the other group. So we had indicated that when a baby is born, we don't do the reverse grouping because the antibody titer is so low. So if that is the case, then we don't expect to see a reaction. So if a person unknowingly takes up a sample and run it as an adult, but even though it's a baby, they will have challenge with reading the complete reaction. But the patient history is what will give us guidance as to what needs to be done. So for newborns, ABO antibody production is not detectable until about 3 to 6 months of age. Elderly patient, after you have reached up in age, your antibody titer tends to decrease. It's just like a female. When she is 20 years old, she is fertile. When she is 50 years old, her fertility rate is decreased. When she is 90 years old, it's almost non-existent. All right, so the possibility of impregnating a 90-year-old woman, no matter how young you may be, is almost impractical. But if you are strategic, it may be possible for you. So, but let us get back to the meat of the matter. The idea is that elderly patient, the production of the antibodies is depressed. All right. So patients with leukemia, example, the chronic lymphocytic leukemia or lymphoma, or patients with malignancy, such as malignant lymphoma, demonstrate hypo, which means low, gamma, globulinemia or globulinemia. All right. So it's hypo, gamma, globulinemia. All right, so it's low level of basically globulin, gamma globulin, which is protein, and leads to some level of anemia, right? So it's blood situations. And we will get a little bit more into that in a future sitting. So patient using immunosuppressive drugs. So the drugs that we use play a critical role in how our body reacts. So if you're on immunosuppressants, guess what? Immunosuppressants doesn't only try to help your body to recover by itself. It basically pushes down all the defenses. It tries to impale, and then it allows the body to remount a reaction. So this happens, and when this happens, also you have a situation where you have hypogammaglobulinemia taking place as well. Patients with congenital or acquired gamma globulinemia or immunodeficiency disease will have or express this kind of discrepancy. All right. So patients who have bone marrow replacement, hematopoietic progenitor stem cells, transplants, HPCs, they can develop situations in which their forward and their reverse are not corresponding. So patient whose existing ABO antibody may have been diluted by the plasma transfusion or exchange transfusion can also have challenges with the reverse. And guess what? Patients who have ABO subgroup can have a problem with the reverse grouping. So in order to resolve this discrepancy, forward and reverse testing does not match. First thing you're going to do is investigate if an error in the specimen collection and identification is suspected. So we're going to try to get out the collection criteria where they met. All right. So we're going to note the initial testing time, date it was performed on the patient. We're going to request a new sample if we're suspecting that there was a collection error. Then we're going to repeat the testing. If no discrepancy, then we're going to report the ABO group that we have identified. All right. Then if the initial testing was performed using patient red blood cells suspended in serum or plasma, we're going to have to wash those. We're going to have to wash the patient red blood cell with saline and repeat the testing. If no discrepancies, then we'll report out the ABO blood group. But if there is some unexpected reaction between the forward and the reverse testing, then we have to look up the patient's information, the age, the diagnosis, the medication, because medication plays a very important part, the transfusion, pregnancy history. Then we're going to determine whether the discrepancy is in the red blood cell or the serum, resulting in the observed weakened reactivity. All right. For example, a patient with serum problem will have weak reactions in the reverse grouping. Patient with red blood cell problems will have a weak reaction in the forward grouping. Persons, let's say, both serum and red blood cell problem exists when there's a weak reaction in both the forward and the reverse. So if it is a situation where the patient has a serum problem, we are going to try to run antibody screen, run autocontrol, and run a saline replacement to rule out Rolo. And if that works, then results can be dispatched. If a patient has red blood cell problem, then we have to do a DAT and we're going to run auto control. If it has both, the patient has both, we're going to have to wash patient's cells with warm saline, not just regular saline, but warm saline, and we're going to retest. We're going to run a DAT, we're going to run an auto control, we're going to run antibody screen, because we have to try to figure out what is causing the discrepancy. So these discrepancies can be resolved with the appropriate procedure. Now let us move into type 2 discrepancies. So type 2 discrepancies are associated with unexpected reaction in the forward grouping due to weakly reacting or missing antigen. So type 1 was the reverse blood grouping. Type 2 is the forward blood grouping. Alright, so when we think about the type 2, we're thinking about subgroups of A or B may be present. You know that we have different classes of A, we have different classes of B, so this now would give us a problem in determining the patient's blood group when we're using a commercial antiserial. If the person has leukemia, this may yield a weakened A or B antigen. And Hodgkin's disease have been reported in some cases to mimic the depression of antigens found in the leukemia. We spoke about the acquired B phenomena, which shows a weak reaction with the anti-B antiserial and is most often associated with disease of the digestive tract. So if the person has cancer of the colon, then their blood group may be what we say altered or changed. So when we have situations like this, we have to try to resolve the discrepancy. So the agglutination of weakly reacting antigens with the reagent antiserial can be enhanced by incubating the test mixture at room temperature for up to 30 minutes to increase the association of the antibody with the red blood cell antigen. If the reaction is still negative, then we're going to move to the next step, which is to incubate the test mixture at 4 degrees for 15 to 30 minutes. So we're going to include group O and autologous cells and controls. All right. So red blood cell can also be pre-treated with enzyme and retested with reagent antiserial. The acquired B antigen arises when the bacterial enzyme modify the immunodominant blood group A sugar, which is the one that we say was difficult to call, the N-acetyl D-galactosamine, all right, into the D-galactosamine, which is sufficiently similar to the group B D-galactose to cause the cross-reactivity, or cause it to cross-react with the anti-B antiserial. This pseudo-B antigen is formed at the expense of the A1 antigen and disappears following the patient's recovery. So after the person would have been treated for their condition, whether it be the E. coli has been removed from their system, they will have their blood group coming back to what it needs to be. All right, so blood group reagents are usually monoclonal. So the monoclonal B, it strongly agglutinates cells with acquired B antigen. The pH of the reagent contains E S4 has been lowered, and consequently only those cells with the strongest example of acquired B antigen react with the antisera. So we can use this to determine what is causing the reaction. All right. So there are other methodologies that we can use in resolving the discrepancy. But let us move into understanding the type 3. We did type 1, which was the reverse, type 2, which is a forward. Now let us move to type 3. So type 2 is the forward, type 1 is the reverse, type 3. These discrepancies occur between forward and reverse grouping and are caused by protein or plasma anomalies or abnormalities or anomalies, right? And results in rouleau formation. So rouleau formation basically means the cells stacking on each other to give you an appearance macroscopically as agglutination. So we call this a pseudo-agglutination. All right. So this situation occurs when there is elevated level of globulin from certain diseases states such as multiple myeloma, Waldenström or Waldenström's macroglobulinemia, other plasma cell situations, and advanced stages of Hodgkin's lymphoma can cause this to happen as well. So with type 3 discrepancies, we can have elevated level of fibrinogen. Yes. So if there's an elevated level of fibrinogen, then we are thinking type 3 discrepancies. When we have plasma expanders, such as dextran, we can expect this to happen. When we have Wharton jelly in the cord blood, that is why we usually wash the cord blood before we perform the ABO testing, because we want to get rid of the Wharton jelly. So these things can impact and give us a discrepancy that we don't really need to have in our reaction. So the common resolution rouleau is basically the stacking of the erythrocytes, the red blood cells, going on each other that adhere and forms a coin-like fashion. It appears in a coin-like fashion, giving the appearance of an agglutination. So this can be observed on a microscopic level. When we look at it from a macroscopic, just using our eyes looking at it, it looks like an agglutination, but that is not the case. We have to take that under the microscope to see if it's truly an agglutination. So cell grouping can usually be accomplished by washing the patient red blood cells several times with saline, performing a saline replacement technique with what it does is that it frees the cells. In the case of rouleau formation, in the reverse type, all right? In this procedure, serum is removed and replaced by an equal amount or equal volume of saline. In true agglutination, red blood cell clump will still remain after the addition of saline. Rouleau can be a nuisance in the laboratory since it is an in vitro problem observed during laboratory testing. It is not an in vivo problem from the patient. So it's basically the testing procedure, the conditions are not suitable that causes the rouleau formation usually. So we have to be very mindful of ruler formation, and this can clog your hematology analyzer. It can cause you to spend a longer time in the transfusion department than you need to in resolving discrepancies. So we have to be very mindful of the rulers that exist. But usually washing the cells would get rid of most of the jellies that may be present, the excess proteins, as well, doing the replacement therapy that there usually helps. All right, now let us move into type 4 discrepancies. So these discrepancies occur between the forward and the reverse grouping are due to miscellaneous problems that have the following causes: cold reacting or cold reactive auto antibodies in the red blood cells are so heavily coated with the antibodies that they are spontaneously agglutinating independently, that there can be problematic. So without even adding the reagents, auto antibodies just jump on each other and start to agglutinate. When we have a situation of a circulating red blood cell of more than one ABO group due to probably a transfusion, a bone marrow transplant, a stem cell transplant, we can have discrepancies. When we have unexpected ABO isoagglutins, that can be a reason to have a discrepancy taking place. When we have unexpected non-ABO alloantibodies, that too can create some discrepancy. What we are going to do is just in brief think about it. How would we solve a situation like this? So the possible resolution to a situation where we have cold reacting autoantibody is potentially cold reacting autoantibody causing the spontaneous agglutination. What could we do? It's cold. So if we add heat to it, then maybe, just maybe, this will resolve it. So to resolve this discrepancy, the patient red blood cells should be incubated at 37 degrees because that is the temperature that the body reacts ideally for a short period of time, then wash with saline at 37 degrees as well. So we're going to keep everything warm. We don't want the temperature to fall, because if the temperature fall, it will auto agglutinate again, right? We're going to wash with 37 degrees saline, so the saline has to be warm. Wash with 37 degrees saline 3 times, and then we're going to repeat the typing. If this is not successful in resolving the forward typing, the patient red blood cell can be treated with 0.01 mole DTT to disperse the IgM related agglutinin. As for the serum, the reagent red blood cells and serum can be warmed to 37 degrees for 10 to 15 minutes. So you're gonna do a mixed tested. It's going to be mixed and tested, and then it's going to be read at 37 degrees. So there are many ways that the discrepancies can be resolved. So these are just some of the discrepancies that exist. I just wanted you to have an idea that discrepancies in the ABO do exist, and we're going to go through the flowchart of resolving these discrepancies in our next sitting. So this moment was just for us to have the idea of the existence of these discrepancies. So now that we have the idea of the existence of these discrepancies, the next thing that we are going to do is to move our minds into resolving them. So, with that said, class is dismissed. Have yourself a great day.